Hello, I'm Jag Singh from Medscape Cardiology. I'm here at ACC 2022 at DC. I have with me here Dr. Christian Jones from the RIS Hospital in Copenhagen, Denmark, who is out here at the ACC presenting a late breaker clinical trial. Welcome, Christian.
Thank you very much.
So Christian is presenting a late breaker clinical trial looking at biomonitoring, bioloop monitoring in patients post-MI with a preserved ejection fraction. So really novel concept. Christian, can you kind of give us an overview of the study and what you found in the study?
Yes, thank you, Jack. So the background for the study was that we have seen in multiple trials that arrhythmias of all kinds are very predictive for major cardiac events in post-MI patients. And recently we have seen that in trials using implantable cardiac devices, that even the asymptomatic shorter-lasting arrhythmias are very predictive. But there's been no major trials investigating if we can actually respond to these arrhythmias and change the prognosis. And that's why we designed the BioGuard-Me trial to where we randomized post-MI patients.
You call it BioGuard-Me?
BioGuard-Me,
Okay.
BioGuard-MI.
MI,
Yeah,
okay,
because it's
got it.
myocardial infarction. But,
Got it. Yeah.
So people here were randomized. We used CHA2DS2-VASc score as an easily clinically usable risk factor score because we knew we had to use high-risk patients. So they had to have a CHA2DS2-VASc score of more than 4. They were men, or 5 in women. And then we randomized them to ICM implantation. And then we actually let them go and just follow normal routine follow-up at the local hospital or cardiologist. And if we saw an arrhythmia, there was a central monitoring board that would adjudicate arrhythmias, and we had pre-specified arrhythmias per protocol. And if we saw an arrhythmia, the board would notify the site, and we would record the time to response. And we also had pre-specified an algorithm of responses, and then we would record if a major cardiac event happened later on. So we had sort of the arrhythmia and the time to response and what response it was in the arrhythmia. So that was the concept of the trial.
And how many patients did you recruit, and what did you find within the subsets?
We recruited 790 patients, so 398 had an ICM, I think. And we found that, it was actually on the way, the first interim analysis showed inconsistencies in the reporting of major cardiac events. There was an independent phone board that would call patients every 6 months. And there were some events missing. And the DSMB, the Data Safety Monitoring Board, warned the sponsor. And there was a large effort done. And unfortunately, after 12 months where we tried to find these endpoints, the trial was eventually stopped prematurely. And there was 218 out of 372 expected events at that time.
Got it.
But when the trial ended, the main primary outcome and the entire cohort, the outcome was not changed significantly, unfortunately. But we did pre-specify the type of infarction, and we stratified patients per protocol into non-STEMI and STEMI patients. And in the non-STEMI group, there was a significant reduction with more than 30% in the primary outcome and not in the STEMI group. And we, of course, tried to look for this reason why there was this difference. And we noticed that there was a higher risk in the non-STEMI group. They had a 75% higher risk of the primary outcome than the STEMI patients. And so, which made sense because we had to have a risk that we could reduce.
Sure.
If there's no risk, you can't reduce it. So it just seemed that in this group, the ICM arrhythmias were associated with a worse outcome, and when you intervened, it reduced it, and the risk was not high enough in the STEMI group. And we sort of, is it really related to the type of infarction, or is it something else. So we looked for other high-risk groups, try to identify them in the control group, and then apply them on the ICM group. And for all high-risk groups, the picture was the same. So if you have a high risk, then you benefit from intervening for these arrhythmias. And if you have a low risk, then there's not enough risk to reduce the outcome.
That's really interesting. Can I just take a step back, and can you tell us what arrhythmias that you found within these patients that required an intervention? And so I'm just going to say 790 patients substratified into ICM, non-ICM, followed along. In the ICM group, you found some arrhythmias. What were those arrhythmias that were actionable?
Yeah, sure. As expected, the main intervention was starting anticoagulation for AFib. But there was a lot of bradycardias as well. And so a large portion of pacemakers were put in, and medication changes, mostly a decrease in beta blockers or other medication changes. There were quite few. There were, I think, 11 ICDs and some ablations done, but that was not a major part of it. And the main outcomes of the primary endpoint, which was a combined endpoint, was new coronary events and the worsening of heart failures. And those were mainly present in the non-STEMI group. So those were the main endpoints we intervened for.
So the non-STEMI people who had the ICM had an intervention and a changed outcome in those patients.
Yes.
But in the STEMI people, there was not enough events for a change in outcome? Or?
Fewer events,
okay.
And of course a less effect of doing anything to the arrhythmias. Yeah.
So why this difference between non-STEMI and STEMI? Why do you think the non-STEMI people were, had this kind of response?
Yeah, that's going to be purely hypothetical, I guess, and just my opinion. But I think they just simply represent a later stage maybe of the disease. So maybe that could also mean that had we followed the STEMI group for a longer time, we would see the same effect, because they would just simply have the effects later on that we could
So were the non-STEMI overall sicker than the STEMI patients? Were they older? Did they have more comorbidities? Or
we didn't find a strong signal towards that. They just had a twice as high risk. There were less, some of the medications they received less frequently, and they had a slightly higher CHAS-VAS score, but not a lot. So it's not a strong signal where we can say these points were important. It was just that they had a much higher risk. So certainly identifying the best high-risk groups is very important for this treatment strategy.
So what is your take home from this? Should we be screening patients post-MI and substratifying them into STEMI and non-STEMI, and then isolating the non-STEMI and implanting loop recorders proactively in these patients? Yes or no? Or is there a subgroup within the non-STEMI that you think might be more, higher risk that we need to focus on? Any thoughts on that front?
Yeah, that's a very good question. So I think first take-home message is, you can monitor anything in the body nowadays. You could also have been monitoring blood sugar and all these things. And I think the trial shows that if you monitor for asymptomatic arrhythmias and you intervene, then in the high-risk patients you can actually prevent hospitalizations and other events. And I think, yes, I'm not. We are looking very much into the right high-risk group these days. So right now the best bit is the non-STEMI group, because they seem to be at high risk with a CHAS-VAS risk factor score of more than 4, 4 or more. But we are certainly looking into presenting the right high-risk group.
That's terrific. So it's certainly. I think the interesting thing is what you've suggested. I like the name of your study, BioGuard MI, because what you're trying to show out here is that the arrhythmic events are serving like biomarkers, right? Because the ones who
more.
had bradycardia or conduction block or AFib
is a sign of some
some disease
progression in
subset.
heart disease. Yeah,
Exactly, indicating that they probably have more worsened cardiac status as compared to the STEMI group, probably. So I think it really makes sense to kind of consider, at least at this stage, before we decide and develop further strategies to validate what you found, to change clinical practice from that. Just a quick question: do you think there's any role in wearables, watches and smartwatches, in trying to be able to document some of these things?
Yeah, it's a very good question. I mean, many of these asymptomatic arrhythmias are nightly. So you'd have to wear the watches at night, but I think you also need a good noise to signal ratio, and you need some good algorithms to take out the untrue arrhythmias from the. But sure, I think the future will show us what type of devices we're going to use for this intervention. Sure.
Fascinating, fascinating. Well, Christian, thank you so much for this phenomenal late breaker. Congratulations to you and your team for conducting such a tough study. I can only imagine how difficult this study was to do. And I think it's certainly enlightening and practice changing potentially. So thank you again for being here.
Thank you very much.